Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled, Health System Science and Global Health Policy, a Framework for Resilience. And I have to say, I am just so incredibly excited you're joining us for today's deep dive. We are tackling a massive topic today, one that really dictates the trajectory of all our lives, but usually entirely behind the scenes.
Yeah, it's the invisible backbone of global health, the systems themselves.
Exactly, our health systems. And to do this, we've pulled together a really dense, frankly fascinating stack of sources. We're looking at comprehensive overviews of global health policy, the evolving field of health system science, and some really critical material highlighting the role of academic dissemination, specifically looking at the work championed by the Georgian Medical Journal.
Right, because getting the research out there is half the battle. It really is. So our mission today for this deep dive is to look right past the individual doctors. Look past the waiting rooms in the local hospitals. We all know a health system isn't just a brick-and-mortar facility. It's the invisible policy framework that's keeping the lights on.
And deciding who gets to walk through the doors in the first place.
Right. But what our sources today reveal is how incredibly fragile the connections between those policies really are. And what happens when you apply real pressure to them.
Okay, let's unpack this to start us off. When we zoom all the way out from the localized clinic, what is the actual scope of a health system functioning at a national or global level?
The scope is staggering, honestly, when you view it from a macro perspective. A health system is the complete institutional, organizational, and policy framework that allows a country to deliver healthcare services to its population.
It's the whole machine.
The entire machinery. It has to be perfectly synchronized. I mean, it is not just the delivery of care at the bedside. It is the generation of the resources required to provide that care. We are talking about the regulatory bodies that approve a new medical device. We're talking about the economic taxation models that fund public health initiatives.
The educational pipelines, right. The schools churning out nursing graduates.
Exactly. And the logistical supply chains moving sensitive biomaterials across borders. It is a massive, complex, adaptive system where a single policy shift in one sector it reverberates through all the others.
So when we talk about the synchronization, we are really talking about aligning incredibly disparate elements. Workforce, technology, financing, governance. How do massive international organizations actually view this alignment? Because honestly, it sounds like managing a health system is less like practicing medicine and more like running a small, highly volatile country.
It really is.
Yeah.
And if we connect this to the bigger picture, international organizations like the World Health Organization view these systems not as a secondary support structure, but as the absolute non-negotiable foundation for achieving universal health coverage, UHC.
The ultimate goal.
Right. They are the bedrock for improving overall population health outcomes. The prevailing view in global health policy right now is that without the overarching system holding it all together, the individual medical breakthroughs, no matter how advanced or well-funded they are in isolation, they simply cannot reach the populations that need them.
Because the delivery mechanism is broken.
Exactly.
Yeah.
You cannot achieve universal coverage if the framework delivering it is fragmented or siloed.
Universal health coverage is a great conceptual target. I mean, everyone wants that. But mechanically, how does a framework actually deliver that without fragmenting? Because the WHO uses a specific model in our sources to break down this complexity into 6 foundational building blocks.
Yes, the 6 building blocks are essential to understand here.
Right, and they are service delivery, the health workforce, information systems, access to essential medicines, financing, and leadership or governance. But listing them out is the easy part. The friction between these blocks is what seems truly compelling to me.
Oh, the friction is everything.
For example, you can have Block 4 essential medicines, but if Block 5 financing cannot handle the cost, the system stalls out. How do policymakers actually balance the friction between these interconnected pieces?
That friction is the defining challenge of modern health policy. Take the tension between financing and essential medicines that you just mentioned. We are currently seeing the introduction of novel, incredibly expensive gene therapies, advanced biologics that cost a fortune.
$1 million single-dose treatments, right?
Exactly. So a public health system might have the political mandate to provide equitable care, that's the governance block, and they might have the specialized workforce to administer the treatment. But if the financing block is based on a traditional taxation model that hasn't accounted for these astronomical new costs, The system faces an existential crisis.
It's a zero-sum game at that point.
It is. Do they fund the gene therapy for a few, or do they fund basic preventative care for millions? The interdependence means that innovation in one block often severely stresses another block.
And I imagine data is what policymakers use to make those impossible decisions. Information systems, that's block 3, must be the nervous system trying to make sense of all this friction.
Data is absolutely the central nervous system, but it presents its own unique systemic friction. The real challenge health systems face today isn't necessarily collecting the data. We have electronic health records, we have continuous biometric monitoring, we are generating petabytes of information.
Because we have the numbers.
We have the numbers. The challenge is interoperability and translation.
Yeah.
It's getting the clinical data from a rural outpost to communicate seamlessly with the centralized National Health Ministry. And then, crucially, translating that raw data into actionable public health policy. Data is entirely useless if it remains siloed on a local hospital server.
Which brings us directly to a key piece of our source material regarding how we break down those silos. Our sources heavily emphasize the role of academic dissemination in bridging this gap, specifically highlighting the Georgian Medical Journal. The function of a scientific journal in this ecosystem isn't just to act as an archive for data, is it?
Not at all.
It acts as the actual conduit between the researchers analyzing the friction and the people running block 6, the governance and leadership level.
That is the crucial link. The Georgian Medical Journal and robust peer-reviewed platforms like it, they serve as the translation engine of a health system.
The translation engine, I like that.
Yeah, because when researchers conduct a complex study on, say, why a specific health workforce retention strategy is failing in transitioning economies, that data needs an authoritative vehicle to reach policymakers.
Right, a health minister isn't just browsing raw server data.
Exactly. By publishing and disseminating these findings, journals inform actual health system reforms. They take isolated, highly technical systems research and convert it into the structured, vetted evidence base that a health minister needs. They use it to justify a major shift in the national budget or a change in medical education pipelines.
So what does this all mean? It means that a health system is essentially a house of cards, but one that is constantly trying to reinforce itself through data and research. The interdependence is total. The governance relies on the data relies on the workforce to collect it, the workforce relies on the financing to be paid, and the financing relies on the governance to allocate it.
It's a continuous loop.
If any single connection weakens, the entire structure is compromised.
It is compromised, but systems can often mask those compromises during periods of relative stability.
What do you mean by mask them?
Well, a fractured supply chain or a misaligned financing model might just manifest as a localized shortage of a specific generic drug, or maybe slightly longer wait times for elective surgeries.
So it just feels like an annoyance to the patient.
Right. The population adapts, and the systemic flaw becomes normalized. The true nature of that interdependence is only fully revealed when the system is subjected to a massive, sudden external shock.
And we definitely don't have to look to history books to see those connections snap under pressure. Here's where it gets really interesting, because we all just lived through the ultimate modern stress test for global health architecture, the COVID-19 pandemic.
The ultimate stress test.
Our sources point out that the pandemic completely stripped away those normalizations you mentioned. It laid bare the mechanical realities of how these systems function when pushed to the absolute brink.
The pandemic provided a ruthless audit of global system capacity. It shifted the conversation from theoretical policy to immediate survival. What the COVID-19 stress test demonstrated was the stark difference between a system that is merely well-funded and a system that is genuinely resilient.
Resilient being the key word there.
Absolutely. Because before the pandemic, many nations equated systemic strength with high-end hospital beds and advanced surgical technology. But the true measure of a health system's resilience during the crisis wasn't solely in its ability to fight the novel virus.
Right, because there's a whole other side to the hospital.
The ultimate metric of success was a system's ability to absorb the pandemic shock while simultaneously maintaining essential, routine health services.
That is the critical distinction that often gets lost in the retrospective analysis, because during the pandemic, the baseline medical needs of the population did not pause. People still needed dialysis. Maternity wards still needed to function.
Heart disease didn't take a break.
Chronic heart disease didn't magically disappear just because there was an infectious disease crisis. So when we talk about system collapse in this context, what did that actually look like mechanically behind the scenes?
Mechanically, The collapse manifested heavily in the supply chains and workforce allocation. Consider the logistics of medical oxygen. It is a fundamental requirement for countless routine procedures. When the pandemic caused an unprecedented surge in respiratory distress, the oxygen supply chains were completely overrun. Borders closed, which disrupted the international transit of raw materials.
So it wasn't just that COVID patients needed the oxygen?
No, it meant that a patient requiring a routine surgery, completely unrelated to COVID-19, could not receive care because the facility lacked the basic anesthetic support.
Wow.
Or consider the workforce. Oncology wards were repurposed, specialized cancer nurses were drafted into intensive care units to manage ventilators.
Leaving the cancer patients highly vulnerable.
Exactly. The collateral mortality, the deaths resulting from the suspension of routine care, was devastating. It highlighted that a system's strength is truly defined by its weakest logistical link.
So COVID-19 exposed that our supply chains, our workforce distributions, and our financing models are deeply fragile under external pressure. Which leads to the obvious next question. Who actually sits down and figures out how to rebuild that architecture? If the WHO blocks are failing, how do we engineer better ones?
This is where the emerging field of health systems science becomes critical.
Health system science.
Yes. Traditionally, medical science focused on the pathogen, the patient, and the treatment. Health systems science shifts the focus to study the system itself.
I see.
It is the rigorous, evidence-based investigation into how healthcare is delivered, how professionals work together, and how the health system can actually improve patient care and delivery. It is treating the hospital, the supply chain, and the insurance model as the patient that needs to be diagnosed and cured.
That's a great analogy. So instead of studying the virus under a microscope, they're putting the hospital's logistics network and the national health budget under the microscope.
Precisely.
What are the specific structural areas these researchers are targeting to optimize care? How do they build that resilience we lacked during the pandemic?
The research is highly targeted. One major focus is exploring alternative healthcare financing models. Researchers analyze the macroeconomic outcomes of shifting from fee-for-service models, which incentivize sheer volume of procedures, to value-based care models, which incentivize actual patient outcomes.
Paying for health rather than paying for tests.
Exactly. They are also heavily focused on primary healthcare integration. This involves studying the architectural and digital pathways required to ensure that a patient's first point of contact, like a local clinic, is seamlessly connected to specialized secondary care.
Without the patient getting lost in the bureaucratic maze.
Right, because that happens far too often. Furthermore, they are analyzing quality assurance mechanisms. They're trying to develop standardized, cross-border metrics to measure whether a system is actually delivering safe care, rather than just measuring how much money it spends.
And the academic dissemination piece we discussed earlier circles right back around here. Running a massive multi-year study on the efficacy of value-based financing models doesn't fix a broken system unless that research actually reaches the people holding the purse strings.
It has to reach the decision makers.
The Georgian Medical Journal publishing these complex systems analyses is the actual mechanism that turns academic theory into legislative reform.
What's fascinating here is how all of this rigorous academic research and necessary journal dissemination connects back to the ultimate global targets. Rebuilding these systems using evidence-based health systems, science isn't just about preparing for the next pandemic.
It's bigger than that.
It is deeply tied to the Sustainable Development Goals, or SDGs, set by the United Nations. Global development goals related to poverty eradication, gender equality, and economic growth are intrinsically linked to health.
You can't separate them.
You cannot lift a population out of poverty if a single medical emergency bankrupts a family because the financing block of their health system is broken. Achieving the SDGs requires resilient, equitable health systems as the foundational prerequisite.
It is the prerequisite for a functioning society. Everything else we want to achieve globally relies on a population that is healthy enough and financially secure enough in their health to actually participate.
Precisely.
To synthesize all of this for you listening, the next time you interact with the medical world, remember that you are stepping into a massive, deeply interconnected web. Health systems are the complex policy frameworks that govern our well-being. The friction between their building blocks determines our access to care.
And their underlying resilience dictates our survival during global shocks.
Right. And the continuous, rigorous research shared through platforms like the Georgian Medical Journal is the toolset we use to rebuild them stronger.
This raises an important question for the future of these frameworks, though.
If strong national governance, traditional physical facilities, and highly localized human workforces are the foundational building blocks we rely on today, how will the rapid rise of decentralized digital health technologies force us to completely redefine what a health system is?
That's a huge shift.
As AI diagnostics and remote biometric monitoring bypass the traditional clinic entirely, will the health system of the next decade be defined by cloud infrastructure rather than hospital beds?
That is a brilliant point, and definitely a paradigm shift to keep an eye on as technology forces the policies to evolve. Well, thank you so much for joining us on this deep dive. We hope it gave you a completely new lens through which to view the invisible machinery of global health. Keep questioning the systems around you.
Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.